So, last but not least, next speaker is the lead facilitator of the Incidental Findings Task Force, Nayana Lahiri. She's a consultant in clinical genetics at St. George's University Hospital in London. She's also the convener of the UK Predictive Testing Consortium. So this is a recently active task force with a specific objective that I mentioned previously. So in this case, the objective is to develop best practice guidelines on incidental findings in genomic studies in Huntington's disease for the EHDN network. And that's what she will be presenting. Welcome.
Thanks very much, Kristina, and thanks to the organising committee for asking me to speak today about the work that we've been doing. So this task force really came about over a glass of wine with Leslie in 2018 in Vienna. And so she had really clear ideas, and bringing people together was, you know, her modus operandi. So this wouldn't have happened, any of this work, without her. So what is the purpose of the Incidental Findings Task Force? So it's to establish best practice for genomic sequencing research studies involving the EHDN, which I'm going to talk about today. The second part of it is to discuss, to consider the EHDN's approach to handling genetic modifiers and consider guidance for implementation into clinical practice or disease-modifying therapy stratification, which we had a first meeting about yesterday with the Genetic Testing and Counselling Working Group and also the Genetic Modifiers Working Group. We had a lovely afternoon, but I'm not going to talk about any of that today. And I'm also not going to talk about the Huntington's disease gene at all for the next few minutes. So you can forget about Huntington's disease for just a couple of minutes. So what is an incidental finding? Well, I'm going to use an imaging example. So if you think about imaging research in Huntington's disease, your primary finding might be to look at research measurements for the caudate or the basal ganglia. A secondary finding would be if you gave all of your scans to a radiologist to look at and they found a brain tumor in one of them. An incidental finding is if there is no routine radiology review of those scans, but a researcher notices there's a big lump in the middle of the brain in an area they weren't looking at. And so what are genomic incidental findings in HD research? So what I didn't tell you at the beginning is that this is not, so this task force is really just focusing on genomic data, not on other types of incidental findings. So what are genomic incidental findings in HD research? They are, so a primary finding might be identifying a useful genetic modifier of age of onset or disease progression. Secondary findings might be looking at all of the sequencing data to try and find variants that could be otherwise medically actionable, so things like increased risk of breast cancer or colorectal cancer genes. An incidental finding is a finding that's stumbled upon in a disease-causing alteration in the course of analysing research data. And so in Huntington's disease genetic modifier research, this is quite important because, as you have heard today, lots of the genes that have been implicated as potential genetic modifiers lie in DNA repair pathways and it is a real possibility that people might stumble across disease-causing cancer genes, for example, in the course of analysing data. So I'm going to give you an example from not a Huntington's disease family, but somebody who I enrolled into the 100,000 Genomes Project in the UK. This was a gentleman with a pure ataxia. He had sort of normal baseline testing, and so we put him forward for whole genome sequencing through 100,000 Genomes Project. And what they found was that he had a single genetic alteration in a gene called ataxia in the ATM gene. So if you have two altered copies of the ATM gene, it causes a condition called ataxia telangiectasia. That's a childhood onset ataxia, causes telangiectasia, which are some skin changes of the blood vessels, and it also causes a high risk of childhood tumors. So this chap did not have two genes, and he definitely didn't have ataxia telangiectasia, but what he was a carrier of a single genetic alteration. And carriers of single genetic alterations are at increased risk of breast cancer, prostate cancer, and pancreatic cancer. So finding this was completely incidental. It wasn't the reason that we had enrolled him into the study, but feeding back that information allowed us to give clinical screening for early detection of cancer for him, and also to do cascade screening for the rest of his family to determine whether or not they might be at increased risk of cancer and have some screening for that. And so we've already touched on this, but the relevance of incidental findings in genomic practice for the EHDN are that the EHDN endorses research studies which make available large amounts of clinical data and biosamples to interested researchers. We're moving on from a period of GWAS where you were unlikely to find incidental findings to whole exome and whole genome sequencing studies where the risk is much greater. These sequencing techniques create extensive data sets about personal genetic constitution. There's a real risk of finding incidental pathogenic variant in a cancer predisposition gene given the direction of genetic modifier work towards DNA repair pathways in Huntington's disease. And as an example, the prevalence of Lynch syndrome, which is colorectal, largely colorectal cancer predisposition genes, is about 1 in 300 in the general population. Prevalence of BRCA1 or BRCA2 variants are approximately 1 in 600 in the general population. And in general, reported secondary findings from whole genome sequencing or exome sequencing studies are around 1 to 6%. And so what we've done through the task force is to identify stakeholders who might have an interest and for whom this work is relevant, EHDN working groups, local research ethics and governmental policy, patients and participants, research funders, EHDN central coordination, and clinical and laboratory researchers. And so what we did was to look at the guidance and to think about people's priorities from each of those groups. At the moment, consents for Enroll-HD and other large studies where samples might become available for do not allow the feedback of incidental findings. And so there's some protection for researchers and participants from there. But I think actually what we need to do is think about whether that's the right thing as a community and what we want to do about it. On the flip side, in coming years, these sequencing technologies will become standard of care in clinical practice, and so there would be less of a risk that those findings won't be identified in the course of clinical care. So the recommendations currently for incidental findings is that we shouldn't currently endorse feedback of any findings from genomic sequencing projects because the infrastructure isn't there and the consents aren't in place. But we would support feedback if a research study set out appropriate consent procedures, had the resource to look for secondary findings, built this into their research plans, was able to validate any research findings in an accredited lab, and to provide the infrastructure for feedback and appropriate genetic counselling for participants. And we think that maybe moving towards establishing the infrastructure within the EHDN that would allow that might be, relevant and good things, and also asking patients and participants and HD family members what their perspective is. So lots of the research done in this area is on general patients and family groups who are having whole genome sequencing, and the vast majority would like to have that information fed back to them, but I think that we can't use that as an as an example for Huntington's disease, because we already know about the want and need of people to find out their genetic status for this. I don't know whether people would also want to find out their genetic status for inherited cancers. They may well do, but we don't know that. So, so there is still some work to do that comes out of the Incidental Findings Task Force. And I'd like to thank all of the members of the task force for all their input over the last couple of years. We hope to have some guidance out in the next few weeks or months, and we're moving on to think about implementation of genetic modifiers. Thanks very much.
Well, thanks a lot, Nayana, and sorry for saying that we were finished before. Any questions for Nayana? Can't see any. Have you thought about where you want to publish your very welcome recommendations?
Well, so I was going to bring them to the EC Festival, Michael, and then we'll have a think about it after that. I think this is particularly for the EHDN because there are already established guidance in lots of other disease areas which have a slightly different sort of slant on feedback of incidental findings. But I think the real risk is actually there are some countries within the EHDN and within Enroll and within Registry that now can't provide samples for sequencing studies because the current consents for those projects don't allow feedback. And there are some countries that mandate feedback. There are some countries that mandate being able to opt in. And so, we sort of need to think about that as a community and what the risk is of not being able to have those samples sequenced.
The very valuable additions. Yeah. Okay. If we have no further questions, then we thank Nayana again for her presentation. And we would like to thank all the speakers of today's sessions for their contributions. And again, we want to thank all the working groups, not just the 5 who presented today, for their efforts in helping us achieve our missions and make a difference to people's lives with